Hello, this is Dr. Daniel S. Anderson, or I go by Stoney Anderson. I'm the President of the Board of Directors of C4, and I want to welcome you to this podcast on increasing colorectal cancer screening rates in California with a focus on the community clinics. I'm a gastroenterologist with Southern California Permanente Medical Group, and I have no other financial relationships with the healthcare industry. So over the next few minutes, I'm going to provide you information on colon cancer in California and provide information on California's present colon cancer screening rates and how we find out what they are. And I'll illustrate some problems we have on knowing what our California's colon cancer screening rates are. And then this conference will provide you with an opportunity to develop methods to increase the screening rates in the clinics for your patients. And then finally, I'll talk to you a little bit about the California Colorectal Cancer Coalition's grants programs, which we award each year, with the grant application coming out in October and having to be turned in December, and then the next year we award grants. They're usually in the amount of about $10,000 a piece. Well, here he is. This is the predator. Now, colon cancer's number 2 killer. The number 1 killer, of course, is lung cancer, which is the alien, and of course the alien can probably beat the predator. But as this slide shows, lung cancer is way up there with 16,000 deaths in California. But colorectal cancer is second, and followed by breast and prostate cancer. You often hear more about breast and prostate cancer because the cancers aren't as fatal as, you're going to have to edit this out, my phone just rung. You stop it? Okay. Sorry. Okay, let's start that slide over again. You most often hear about breast and prostate because as cancers, they aren't as fatal as colon cancer. So there are more breast cancer survivors in California and prostate survivors in California than there are colon cancer survivors, as you see on this slide. Now, the shame about anyone dying from colon cancer is that there's incredibly effective screening tests. And these are the screening tests that are recommended by the U.S. Preventive Services Task Force in their 2016 recommendations. And one is a fecal immunochemical test, which is the stool test that can be done at home. It can be mailed to the patient. They do it at home and they mail it back to the lab. And the way they rated these screening tests or programs is the number of cancer deaths averted per 1,000 screened. And there's about 28 people out of 1,000 will die of colon cancer unscreened. So the FIT test prevents 22 of those 28 from dying. So on a perfect screening program with a FIT test, your 79% of the colon cancers are prevented or are found at a stage that can be cured. You can also do a sigmoidoscopy every 10 years plus the FIT test, and you get a slight improvement where you're up to 23 cancer deaths per 1,000 prevented. Unfortunately, in this country, it's very difficult to get a sigmoidoscopy. And if they're free, it's actually difficult to give them away because we've tried that in Kaiser and also for the California Colorectal Cancer Coalition. And then the colonoscopy every 10 years is even slightly more effective with 24 cancer deaths averted. But as you can see, the confidence intervals in the brackets overlap, so these tests are essentially equivalent. And in California, there's really only 2 tests that are in play, the FIT test every year or the colonoscopy test every 10 years. But this slide shows you that we can largely prevent this cancer from killing Californians if we can get people screened. So over the past, from 1988 through 2012, almost over the past 25, 30 years, the incidence and mortality of colon cancer has been going down. Now this preceded large-scale screening efforts, but with increased screening, which started in about 2000, the slope of the line as far as incidence is concerned has increased. So we think this is due to screening. Now, over these years, the rates have decreased, but the decrease is not equal in different race and ethnicities in California. And this is particularly important for the people that work in the federally qualified health centers who take care of a great number of Hispanic individuals in the state. It's decreased by 39% among non-Hispanic whites, 34%, almost as much in African Americans because of increased screening in African Americans, 27% over Asian and Pacific Islanders, mainly because they're poorly screened, and only 11% in Hispanics, and this is because of poor screening. And the mortality rates are much the same. The greatest decline in non-Hispanic whites, followed by African Americans and Asian Pacific Islanders, and Hispanics, only a 10% decline over this period. And this is due to poor screening, and one of the measures that shows poor screening is how many cancers are found at a late stage, because with screening, you not only prevent cancers by removing polyps, but you find earlier cancers, so you'll have a more early stage diagnosis. But Hispanics have late stage diagnosis almost half the time at 46.3. And trailing behind them are the non-Hispanic whites, and we were very fortunate to see the change in 2012 where the blacks were almost exactly the same as non-Hispanic whites. As you can see, the Japanese and Vietnamese are also doing well. And here's the late stage diagnosis for everyone. As you can see, only the two small ethnic groups are worse than the Hispanics at 46%. So that's the point of this slide. Now this slide shows you that non-Hispanic blacks have the highest incidence and by far the highest mortality. We're unsure why this is, and we do know that with screening and equal access to treatment, once a cancer is found, the mortality in non-Hispanic blacks is the same as it is in whites and other people that have a lower mortality. So we think that this will improve over time, although the incidence will continue to be greater in blacks than whites or Pacific Islanders or Hispanics. If you look at Hispanics, you can see they have the lowest incidence of actual cancer, but they're third in mortality because of the poor screening. So the question is, how well is California screening its at-risk 50 to 75-year-old population? And this is the population that we recommend screening in, 50 to 75 years old. And we have data from national surveys in 2015. The survey data, unfortunately, has problems with method changing over time, and it is survey data, so it's self-reported. And then in California, we have data from chart reviews. This data is difficult to access on the California websites, and I'll reference those on the subsequent slides. And it requires searching single sites or even multiple sites in multiple areas. And HMOs, PPOs, medical groups, and federally qualified health centers have the good chart review data. And it's up to date in 2015. So from what we know from the behavioral risk factor surveillance system in 2014 is that California is better than average. Our screening rate is about self-reported 68.6%. We rank 21st in the nation, So we're better than average, like on Prairie Home Companion, but we're not much better than average. And our screening rates are higher over age 65, where people have Medicare almost universally, and that's about 80% in California, whereas the 50 to 64-year-olds are only at 61%. The blacks are getting screened as well as the whites, but once again, the Hispanic and Asians are around 50%, and the uninsured, which many in the federally qualified health centers are only being screened at 25%. So we have data in 2016 and 17, and it's really from 2015 chart reviews on large HMOs, large PPOs. And then you can get reports on medical groups by counties. It doesn't report on health plans other than large HMOs and the PPOs, and of real distress in Medi-Cal managed care systems that take care of about a third of California's insured population. They are not reporting colon cancer screening. They are reporting breast cancer and cervical cancer, which, as mentioned earlier, kill less Californians. We're trying to change that, but it's going to be difficult, and it may not even be possible until 2019. So here are the HMO screening rates. I fortunately work for Kaiser, Southern California, and we are doing a lot of screening, and we lead the state at 82%, but Kaiser, North California is just barely behind us. And then I have pluses by the people that have increased their rates recently in the last reporting period, but most are sort of stuck in the mid-60s. If you look at the large PPOs, once again in the low 60s and even the 50s, so we're just not doing well. Now, I'm very interested in the California Colorectal Cancer Coalition in our federally qualified health centers that take care of 4 million Californians. And we make up about almost 17% of the United States federally qualified health center patients. So we're big drivers as far as nationally is concerned in the federally qualified health centers. These are patients that 296% are below 200% of the federal poverty level, and about 75% are below the 100% of the federal poverty level. So these are people without a lot of means, and 22% have no insurance whatsoever. The interesting part is that 80% of the insured are on Medi-Cal, and as mentioned earlier, we don't know what the health plans in Medi-Cal are doing as far as screening is concerned. We do know how the federally qualified health centers are doing. The other important part is that they are treating our most vulnerable population in California. 72% are Hispanics, and then 8% are Black and 9% Asian. There's excellent description of these clinics on the HRSA website that's mentioned there at the bottom of the slide. So, how are we doing on our federally qualified health centers? In 2014, we were sort of at the average for the country. We were 34.8. As you can see, they were 34.3. We jumped up rapidly in 2015 to 41.2, a 6.4% increase, which was quite remarkable. And the U.S. only went up 3.8. We're much better in our federally qualified health centers than our general clinics throughout the state. We're 10th in the nation. And we are the major factor in increasing the nation's rate. And if you look at a map, we're the only state in the western 4/5 of the nation with a higher screening rate is Washington, and they're just barely higher by 4/10. So the folks that are listening to this that work in our federally qualified health centers should congratulate yourselves. You're doing well and you're moving up rapidly. So the key to increasing these screening rates at both the federally qualified health centers and where I work in Kaiser Permanente is the use of the FIT test to increase screening rates. And you'll hear more about that in the rest of this podcast. FIT testing is preferred by patients over colonoscopy in numerous studies. The FIT test reduces the number of required colonoscopies, and in some areas of the state, colonoscopies are a resource that's not limitless. And it's ideal for outreach programs such as what you'll hear about later, the Flu FIT program or mailed home screening, where the person does it at home and mails it in and doesn't even have to make a clinic visit. So finally, I would like to just present a little bit about our community grants program, because we want to help the federally qualified health centers and lookalike health centers or any clinics or programs in the state increase colon cancer screening rate. So this is a program that we started 6 years ago at the California Colorectal Cancer Coalition. And the major focus has been on increasing screening rates, as I mentioned, and it's related to our priority area of primary prevention and screening. And the money we get is mainly from the Colon Cancer Alliance through the Undy Run Walk in Sacramento and San Diego. The run walks are always in Sacramento the last Saturday in February and the first Saturday in San Diego. We're also funded by the American Cancer Society. We have close coordination in administering the grants program with the American Cancer Society, the California Dialogue on Cancer, and the California Colorectal Cancer Comprehensive Control Program. The grant applications, as I mentioned earlier, are released about October 1st and deadline is usually November 30th. So you can get a look at our program on our website, cacoloncancer.org. Now, as you can see, we are increasing the grants each year. We were in 2017. This year, we were able to award almost $92,000 in grants. And once again, there's our website for a more complete description of the grants. So by using more FIT screening, in California, we screen about 20% of our population with a FIT test. The FIT screening program is more cost-effective and actually is cost savings in the health system. It's the only cancer screening test it is. And if you put a person in a FIT screening program, you'll save the healthcare system $487. And the reason is late-stage diagnosis of colon cancer has very expensive chemotherapy. So this is something that was reported in 2015. California's healthcare savings would be $132 million if 30% of our population instead of 20% of our population of the unscreened population California needed to reach 80 by 18 were screened with the FIT screening program. This can be done, and where I work in San Diego and Kaiser, we screen about 40% of our patients with FIT screening. So we encourage you to adopt these programs not only because you'll save lives, but you'll be saving money for the healthcare system. So thank you for your attention to the subsequent talks. Remember, you are saving lives. You only have to screen about 60 people or make sure they're in a screening program to save one person from dying from colon cancer. And remember, offer colonoscopy if you have the resources, offer the FIT test. Just make sure the screening test is done, because we know that the best screening test is a screening test that gets done.